Welcome to the Pivotal Podcast. Today we're joined by Joe Martinez, Program Director of Nursing Informatics at York-Presbyterian Hospital. Joe has a rich background in nursing and health informatics with extensive experience in both clinical practice and technological innovation in healthcare. In this episode, we'll explore Joe's career journey, his current projects, his insights into nursing informatics, and his passion for improving healthcare systems. Joe, thank you so much for being here with me today.
Absolutely. Thank you so much, Ben. Really excited to be here.
Yeah, absolutely. So let's start off. Just catch me up. What kind of work are you doing right now?
Yeah. So how do I spend my days? I get to do really cool projects in an awesome hospital system. What I get to do is implement the latest technology into nursing practice itself. And so what does that mean exactly? If we have any problems or any solutions that we're really trying to hunt down in terms of quality or safety, efficiency, we try to see what technology is out there and try to, pair it with the right clinical solution. And that's my day to day. It's pretty cool.
Yeah, that's super cool. That sounds awesome. And I think I have an idea based on just that description, but what do you love about it?
Ooh, at the end of the day, I would describe my job sort of, I used to be an ER nurse and I was a caretaker for patients. And I kind of see my job now as the caretaker of the caretaker now, if that makes sense. And I love to solution and find problems. And that's kind of how I spend my day, just trying to find those really juicy problems that, we're really stumped on. Sometimes, at the end of a shift, nurses can be really tired and exhausted, as you can imagine. And consequently, getting that feedback from them about what we can do better for them can be tough. But when we do get it, it's really awesome information from them. And so that's my favorite part of the job, just being sort of the caretaker of the caretaker and the problem solver.
Yeah, cool. Is there anything that you wish were different?
Ooh, good question. Different. I think, there are things that I kind of understand why they are the way they are, but just in healthcare overall, implementing change, as you can imagine, I know this won't be surprising to a ton of folks, but it can be slow. And a lot of my background is in startup health tech. And so the speed at which we move there can be very quick. Implementation from ideation to go live can be weeks or months. And, when you're at a larger hospital system, any hospital system really, things have to be done in a very specific way, because we are dealing with real patients, we're dealing with real people, and there are real consequences to anything that we do really well or not so well. And so as a result, things have to move slow. Being an old ER nurse, I like to move quick. I like to move very fast. And I'm also pretty tactile. So sometimes I do struggle with the pace of change. Being a little, not as fast as I would like, but I would say I completely understand why it is the way it is, because we have to make sure, we do things the correct way. There are a ton, as you can imagine, a ton of implications to the great work that we all do in informatics. And so we understand that. And so we have to make sure that, things are done correctly before we go live or implement any kind of cool technology out there.
Yeah, for sure. So now you've mentioned ER nursing, you mentioned health tech. So let's put all those pieces together. Where'd you get your start and how did that lead to where you are right now?
Yeah, well, I've been in healthcare for about 20 years or so. And I entered the healthcare realm as an ED nurse at a level 1 trauma in Dallas, Texas, where I'm originally from. And that was my introduction into healthcare. And boy, was it an introduction into healthcare. At a level one trauma, you really see everything under the sun. You get exposed to a lot of the parts of healthcare that are, a little deficient, and you get parts where you're just really surprised at what you find. And that really laid the foundation to how I view healthcare today. And it gave me a unique perspective on the problems we have in healthcare. What happens to patients when they don't get the access they need? What happens to a mother when she has no prenatal care, and the first prenatal care they're receiving is when they come into the ER? I've witnessed that quite a bit at the ER I was at for several years. And this isn't a brag by any means, but we delivered the most babies out of any ER in the nation at one point. And most of those were parents with no prenatal care. And so just to witness that was a big surprise, but that really got me started into, how can we start to solve these problems? There are so many places to start, and it can be overwhelming. But what I've learned is, really start somewhere and give it all you got. And that's kind of my approach. And I saw a lot of the workflows, a lot of the technology come together in ways that I thought could be better, that were great. And being an ER nurse, I was the end user for a lot of these technologies that were being implemented. And I thought to myself, how can these be better to serve the nurse, to serve the caregiver, the providers, the doctors, everybody, and how can we better support these patients? And so that's when, after 7 or so years in the ER, I slowly made my transition from bedside care to more of the tech side, informatics side of healthcare. Yeah.
Okay. And what did that initial informatics role look like?
Yeah, my first role right outside, right after the ED, was telehealth. And so I was a supervisor for a telehealth company. And what our role is our job was to help keep patients from returning back to the ER. And so providing those patients that are highest at risk for coming back to the ED, a lot of those chronic illnesses like diabetes, heart disease, and really target those patients to help them transition home much better, in a more successful way, and really get them the most important resources they had to have to keep them out of the ER. And a lot of that was, you'd be surprised to know that over 80% of those patients that are leaving the ED don't have any kind of follow-up care. They feel better, their symptoms go away, so they must be cured, right? And so our job was to help them transition to home a little more successfully with much more support in their home and in the context of their home. And so in that initial role, I really helped redefine those workflows, helped deploy the technology in a way that was really easy for those patients. A lot of those patients at that time weren't using a lot of mobile apps for their health. This was 17 years ago, so there wasn't a lot of mobile apps. And so we were doing a lot of telehealth by phone. And so just making sure that we were targeting those patients before they left the hospital, so they understood exactly how to access those telehealth services. And so a lot of my role was overseeing operations for that and helping to optimize those operations as well. And that was a lot of fun. And at that time, the adoption of telehealth, the adoption of remote technology wasn't as high as it is now. And so back then it was much more novel. And so all those challenges that went along with it, folks are like, well, who am I talking to on the other side of the phone? App, how do I enable my Wi-Fi to see videos, stuff like that was coming up. a lot. And so at that time, the nurse just wasn't only the nurse, but they were also kind of a tech assistant to really help them troubleshoot that technology. So anybody that came on board with us at that time, they had to be half nurse and half tech assistant to help those patients get on board. But yeah, that was a lot of fun back in the day.
Yeah, that's incredible. So this wasn't, you mentioned that, 80% of the people that leave the ER have no follow-up care, right? So were you guys, I think I know where this is going, but were you guys scheduling follow-up care for them, or were you actually providing the follow-up care over the phone for them?
That's a good question. It was case by case. We would do both overall. If those patients didn't have primary care, and the instructions advised them to go see a PCP, we could provide that for them. If they needed more of specialty care or perhaps home health care, that was a common one as well. We had some partnerships that we could help very seamlessly so transition those patients to those services. And so it was case by case. Some patients were really complex, and so they had a lot of needs that were beyond our scope, and we recognize that, of course. And so we were able to build a system of resources for those patients to really connect them to those services that were beyond our scope. But yeah, we were sort of a catch-all. A lot of patients just needed a drug refill, and so if they had any kind of those medication needs, we also had resources for those patients. And a lot of those patients, when they're really comfortable at home and in the context of their comfort zone, they'll think of a lot more questions that they didn't have in the hospital, as you can imagine. And so being able to engage a patient during that really important transition and then also, catching them when they're at home, really comfortable, that was really good for us, because we caught a lot of things that typically were just missed. Because, when I'm trying to leave the hospital, I have a lot of things on my mind. Patients are trying to think, how do I get home? What do I have? What is all this paperwork? And so their objective is just to get home. And once they're home, they're like, oh yeah, what is all this? What do I do with all this? And so that was when we stepped in and really tried to intervene in a supportive way for those patients.
Yeah, that's great. So you said that all started about 17 years ago. How long did that part of your adventure last? And how did that evolve over that time too? Because I'm sure it was super different from the end, right, versus the beginning.
Yeah. And, it probably took me years to adapt to that, because, myself, I wasn't a huge advocate of telehealth initially. I was very traditional in the sense that if a patient wasn't feeling well, they should see a person live, in an office. That was the best way. So you can assess the patient and you can see the patient. Obviously, I'm still in this realm, so I'm a huge proponent of health tech, telehealth, informatics, and what have you. But it probably took me 3 years to really master that role. And I was in it for about almost 4 years. After I moved away from that organization, I worked for a much larger telehealth company in Dallas, where we not only provided virtual care to patients, but in-person care to those patients as well. So during this time, virtual care was being combined with in-person care to really care for those patients that were high acuity, that were really sick, that were on the cusp of perhaps almost going to the ER or urgent care, but didn't quite meet the full criteria. That's when we would come in and we could dispatch, those services to the patient in their home. Or, if it was more low acuity, low risk patient, we could do virtual care. And so we we provided care to patients. This one was in all 50 states, as opposed to the previous role. It was just in the DFW area back in Texas. So this one was all 50 states. We provided nursing care, physician visits, health coaching, and remote patient care as well. So we could track all those great, what do you call them, biometrics that were awesome, and it was a huge ordeal to get off the ground, but I'd say it was a first of its kind. Now it's much more popular, but this was almost 15 years ago, and I think it was ahead of its time because it was really tough to get patients to adopt to this hybrid type of care. And we were also trying to compete with their PCPs as well. And that was not the intended aim of the business. We were really trying to complement the care they were receiving with their PCP. And so, but a lot of fun, a lot of just a ton of lessons learned that really served me today, because I can look back and say, yeah, we've tried it. Let's try it. Let's try it this way. Let's try it that way, because I've seen it go not so well and really well. And so those lessons learned were really important for sure. Yeah.
What was the big difference in those instances, and not so well versus going really well?
I think when we initially started, it didn't go well because I think we weren't selecting a really good patient population. I think one question we want to ask ourselves, that I always do now, that I didn't always do consistently back then, is where does this make sense, and who does this make sense for? I think before we were like, well, this is a great solution, let's apply it to all patients. And consequently, there was a lot of low engagement from those patients that really didn't see a ton of benefit, or perhaps they just didn't like any kind of telehealth. They just preferred, a brick and mortar, which is completely fine. But I think it didn't go too well initially, only because we didn't really define our target population really well. Who would be ideal and who could gain the most from this technology, from these interventions. And I think, for me, that's step 2 or 3, is really defining the population there.
Yeah. Can you share what you found there? Like what were those insights? I mean, what does that target population that really engages well with telehealth look like?
Yeah. Well, this was back then. And so we really looked for folks who didn't have a lot of complex needs. If we saw patients who had maybe 1 or 2 health problems, they were ideal. I think for those patients who were really complex, that had a lot of specialists, for us to come in and say, hey, here's another way of reaching a provider, rather than it's being perceived as something that was convenient, it was overwhelming for those patients. And then we also implemented sort of a quick, tiny test to see how patients responded to the technology at first. And if they seemed too flustered and we tried to help, and they continued to seem too overwhelmed, then we would not select those patients, because obviously they would not be able to adapt likely. And so we really tried to understand our patients more, and their willingness to engage in this type of technology. Back then, everybody did not have an iPhone, and so that was an obstacle, with not everybody having a smartphone rather than an iPhone. And so so that was one obstacle. And some patients were just a little too skeptical of who was on the other line. I don't know who I'm talking to. I can't verify any of your credentials. I can't really see your degrees on the wall. And so that was an obstacle too. And so for those patients who were really complex and really just just not ready for the technology, we offered alternative solutions. And I think after that, we were able to really refine who we targeted for these services. That was really helpful. Yeah.
Yeah. So you mentioned previously, or prior to those two roles, you were in the ER, right? ER nurse. So what were your roles at those telehealth organizations?
Yeah. So at the first telehealth, I was a supervisor, then a manager, and you kind of wore several hats. I oversaw quality, I oversaw uh, patient satisfaction, and also worked very closely with our clients. And our clients were hospital systems. And at that time, I really knew what they wanted because I just came from a hospital system, and so I understood, what the end game was, what the results had to be for them to be satisfied. And then my role at the next telehealth company, I started off as head of quality there, overseeing health outcomes, making sure we were really moving the needle on those health outcomes. So if we were treating patients with high blood pressure, were we keeping the blood pressure under control? For those with diabetes, were we keeping their A1C under control, and overseeing those health outcomes and implementing any changes or trainings for our clinical team to help improve those outcomes? It was a lot of, a ton of pilots as well, because we were doing things that really hadn't been done before. And so there was no best practice at those times. And so we were really, it was uncharted territory. And consequently, we had to do a ton of pilots, see how it went. Maybe let's try it this way. Let's try it that way. How do we introduce this technology to patients? How do we get them to feel comfortable? What kind of verbiage? Do we turn the video on or off? And so that fell under my scope as quality, is trying to get the patient engagement up. And so we did a ton of pilots on how can we tweak the workflow here and there to make outcomes better, to make the experience better for the patients, and also just to keep them coming back, if they needed to, obviously. But that was a ton of fun, because I was just doing things that hadn't been done before, and had a blast doing it. Yeah.
It sounds like a great opportunity to regularly flex that problem solving muscle, that aptitude that you mentioned earlier.
Yeah, and it was really out of my comfort zone, which I enjoy. Being in the ED back in the day, I was no 2 days were alike. I never knew what I was walking into, and so same with health tech. Never know what you're walking into. You don't really know what kind of problem you'll be solving and what kind of expertise you'll need. I was becoming an expert in a lot of things at that time. I wore so many hats, but I enjoyed it. I really enjoyed it. And I think it's something, folks either really like or just don't like at all. I've seen folks join my teams in the past that were highly skilled, great experience, super smart, but being in an environment that there isn't a ton of best practice, there isn't a ton of research back then, especially. That could be uncomfortable for folks as well. And where there's not a protocol for everything, in a more traditional healthcare setting, there's established protocols. You're working with healthcare systems that have been around for several decades, and so as a result, they have implemented a lot of policies, a lot of practices that have been around a long time. And so coming into health tech, none of that exists back then, especially. And so you have to be able to bring a lot of order to a ton of chaos, essentially. So, yeah.
That's an interesting thing to consider, I guess, because I know when people get burnt out, they think of, okay, what's an alternative to the bedside, right?
Mhm.
And if they look into health tech, to keep in mind, like, hey, what's your comfort level with uncertainty? Like, what's your
Yeah.
personality type, right? And if you really rely on proven processes and procedures, then something that requires a lot of innovation might not be a great fit for you.
Yes, yes. And I think, I've seen really great folks adapt and rise to the occasion, try to flex those muscles and that experience that they didn't know they had to help solve a new problem. And I've seen some folks, and kind of like myself, the first 3 years I struggled. I struggled because I was used to leaning on a lot of folks who came into the practice with decades of experience in what we were doing. There were folks who taught courses, who had done research on best practice, and I had a lot of foundation to fall back on. But coming into health tech, you don't have any of that. You don't. You kind of have to be comfortable with creating it. You kind of have to, um, be confident in what you do know to be able to extrapolate a solution, and be okay if the solution doesn't go well. You have to be able to dust yourself off quickly, try to pivot and try again, and then if you have to do it again 10 more times. But for some folks, that can be tough. And that was tough for me until I learned to like it. And I really changed the way I see it. I really go in, no matter which day I'm having, with, what's my purpose in mind? What am I trying to do? And I think I get burned out a little bit quicker if I'm not in alignment with my purpose. And so whenever I interviewed folks to join my team in the past, I would want to understand their purpose and see how it aligns, because that's really the secret for me to being more flexible, being more resilient in this, and just having fun with it. I think if you're not having a little bit of fun with it, then you will get burned out with it. And I've seen it happen so many times. And whenever I have felt like that, I have to ask myself, am I doing what my purpose is? I'm like, okay, I need to remind myself. And once I do, it usually, I can course correct. But yeah, I've seen a ton of folks not adapt to it the best, and I've seen some folks take a liking to it and just thrive in it, and that's been so much fun as well.
Yeah, I bet that came in handy really, those first 3 years you're talking about with the struggle, right? Like, hey, I had all this support, all of this best practice, and all of these, mentors with all this experience or experts I could go to, and now I'm figuring stuff out and it feels like a struggle. Did I make the wrong choice moving into this? Like, did you question that? You find yourself doing that?
Yeah. I actually came close to leaving because, coming from an ED, you're running codes, you're saving lives, you're doing everything you do is life saving. You are changing lives, and you don't really stop and think of the smaller things, about the patient experience so much, about how can we modify this workflow and change outcomes, because the role is so tactile. It's, you're just responding to the moment, every moment. And so just you know coming into health tech, I was like, okay, workflows, well, this takes care of the solution. What else do we need to, why do I have to try to break apart this workflow and put it back together 10 more times? We could be saving lives instead. That was my attitude back then. I really felt that I was above it all, and I really had to take a step back and see the big picture and understand, and again, reapply the purpose of what I'm doing. I'm like, actually, these things do make a difference. How we introduce patients to technology the first time really does set the tone for them, really does kind of affect how they'll adopt technology into their own health, sometimes for the rest of their lives. And I think that's an easy thing to just overlook. And I perhaps was a little guilty of that when, in my first couple of years. But now, I see the importance. How we engage patients through technology just has such deep implications, and it could mean the difference between their access to really good healthcare or no access. And so just making sure that their introduction into this realm is really good, making sure that they re-engage, and if they don't, understanding why. Is it something that's within our control? And I see the importance now, for sure.
Yeah, seeing not just like what you should do, but why you should do it. I think the why makes such a huge difference in everything we do.
Yes. And I would say probably more than the solution is just, what is the problem we're trying to solve? I'm not the hugest fan of just implementing a solution or technology for the sake of just implementing it. For example, AI. I love AI. Let's explore it. But I want to make sure that before we apply it to any clinical workflow, we defining the problem? What are we hoping to solve from this? And after that, how are we trying to measure success? How do we know it's going well? Is it just the fact that we implement it and it's okay, there's no huge, there's nothing wrong going on? How do we measure success? And so for me, I just come back to, yes, the purpose. What are we trying to solve or make better? And understanding that probably to me is just more important than the solution, because you can have the best solution, but what are you trying to help? What are you trying to fix? It does a lot of things, comes with a lot of bells and whistles, and so much. But if we don't have a really good use case that's been vetted by key stakeholders, like nurses, like patients, like physicians, like any key member of the care team, then is it that great? And then so I think just making sure that we define the problem, but have the right people in the room. And being a nurse, I'm always advocating for nurses. And so, shout out to my nurses, but I think, having them in the room and encouraging them to speak up, that has been my best tool. To me, it's the secret sauce to anything, is getting those folks to speak up, because they have a lot of solutions in their mind. They have a lot of ideas. They spend the most time with patients out of any healthcare provider, and they have those insights. And so to be able to pull that out of them in a way that's meaningful, I mean, it's worth gold to me. So yeah.
That's huge. I've heard that several times too. I mean, just everything you're saying, echoing the value of nurses, because it's like they see it all. I mean, they're right there. They're the ones with, like you said, the most time in the EHR with the patients, just all these things. And giving them a voice does a couple of things. One, it leads to really effective solutions, right? But two, probably also increases their buy-in and their engagement, and thereby reduces the potential for burnout as well.
Yeah, absolutely. And I think, part of the culture of nursing, really, nurses aren't really known to always share their thoughts and their ideas about things. And so, but there has been a shift in the past decade where we are seeing way more nurses at the table, really speaking their mind, really trusting their experience, really, having more confidence in what they can bring to the table. I think historically, nurses, we had a very interesting dynamic with physicians. It was, Back in the day, it was us just implementing or executing orders. Over the past few decades, and nurses themselves have become very independent practitioners themselves. Me myself, I'm getting my doctorates in nursing and doing nursing specific research with technology, and so it's its own discipline, it's its own practice within itself, and sometimes can become conflated with medicine. And there's a ton of overlap, and that makes sense. But in its own right, it is its own discipline, and so their unique perspective will be unlike anybody else's in healthcare.
Yeah, that's so good. So, okay, you've talked about the ER and then the telehealth roles. What came after that?
Yeah, so about 7 years ago, I made the move from Dallas to New York, working for a startup health tech, because those other companies that I was working for, they were established companies. They were just opening up departments, but they had deep pockets. They were established corporations. When I was in Dallas, we had a partnership with a small vendor that was New York based, and I was really impressed with their platform that they built, and their team as well. And so I just kept my eye out for any openings, and I saw something come up and applied as an operations manager at this health tech startup. And while I was there, just had a blast. I was just exposed to so much. I would say one of the best experiences I got was working with engineering and product teams. Specifically, as a nurse, we speak very different languages than product and engineering, and so I had to learn a little bit of their language, and they had to learn a little bit of mine, and found some common ground. But just had a ton of fun helping with developing their roadmap, helping them design a more a better UX for patients, really helping them understand the value of features that we implemented from a clinical perspective, helping them to quantify that as well a bit. Really help build the clinical team as well in terms of training, expand it from only practicing in one state of New York to all 50 states. That was a huge undertaking, establishing those PCs, finding the right workforce. That alone was enough. But, just doing a ton of pilots as well. We were doing health coaching, primary care, specialty care, urgent care, and then it dialed back a bit because we realized we were doing too much too fast. And so again, going back to defining the problem a bit better, because we can't solve everything. We can't boil the ocean. And so we want to make sure that we took a step back and understood where do we want to focus, go back to the basics. But worked my way up in that organization my last couple of years there, I was VP of virtual care there, and I built the team from the ground up. It was a huge undertaking, and still stay in great contact with all my colleagues there. They're still thriving, still doing great. But I would say that role in particular in New York was probably my most favorite. I had the most fun and learned the most in that role. Yeah.
Wow. And now you're back in the healthcare setting, out of tech, not out of tech, but out of the startup world, I guess.
Yes.
In nursing informatics. What led to that?
Yeah, I think that was sort of always my end goal. I think I wanted to see, when I initially left the hospital system, it was because I wanted to see what else I can learn. What are other ways of looking at the problems in healthcare? The thing about healthcare, it's, obviously it's evidence based. A lot of research goes into healthcare, um, but also it's based on a ton of tradition, and so things, like I said earlier, move sort of slow overall in healthcare. And so I wanted to see how things could be done in a different way. And I think my goal was to always come back home to the health system, to the hospital system. Um, and at that point, I learned a whole lot. Not that I learned everything that there is, but I learned a tremendous amount of things that I wanted to share with my nursing colleagues. And so I had this urge to really go back to my roots, go back to a hospital system where I could really share my knowledge. I could really offer an alternative perspective of viewing problems, solving problems, um, and just offer, some of the things that I've learned in a way that could be leveraged to help patients with higher acuity. Because obviously in a healthcare system, once patients are in a hospital, they're there because they're sick, and it's more than likely the worst day of their lives if they're that sick. And so I wanted to go back to where the need was the greatest, and share my learnings, share the approach that I've learned from working with product teams, working with engineering teams, um, and yeah, and that's how I found my way back into the hospital system. Yeah.
Yeah. So how are you actually spending your days now?
Yeah. So, hospital systems overall, they are very complex. And so I spend a lot of my days making connections with the right folks within the hospital system, getting back, because I'm still getting back into the swing of things, and sort of kind of relearning some of the things I forgot, and really identifying where are the problems, where is the greatest need for us to provide those tech interventions. And so getting to know some key stakeholders, getting to know sort of the data infrastructure. So, because anything that I work on, I want to make sure that it's supported by the data. So really understanding, and there's a ton of data, way more than when I was in health tech. But really, I'm in the phase where I'm really trying to identify those problems. Um, I can't move at the speed of light like I did in health tech, obviously, but I am spending my time really identifying those problems. I'm very gradually wanting to work on some big projects that I see coming down the road that I know I could leverage my experience. But really, what my team does is we identify those opportunities to improve. A lot of them can come from just anecdotes from the people that are providing direct patient care, and it could be someone just saying, "Hey, I need help when I administer this kind of medication. How can we make it easier because XYZ keeps happening?" And I like to understand more about the problem, and going there in person to really see firsthand, which is really nice. Traveling to a site to really get the sense of what the caregiver, what the care team is dealing with. Because for me, I could think about it theoretically, but for me, I'm very hands-on. So I want to see the problem itself. And this is why I came back, because I want to see those problems. And so right now I'm in the phase of really identifying those problems and looking at the technology we have available to us. And we work with a lot of vendors. And now I'm on the other side of it, where I'm sort of the client, and which vendor solution can we implement to really help our caregivers and really help our patients. Yeah.
That's awesome. How would you define nursing informatics?
Ooh, that's a great question. I feel like it changes every year. It changes every year. I would say, and you can ask 10 informaticists this question and get 10 different answers.
That's why I ask it.
Yeah, but for me, I think it is identifying data, analyzing that data, and drawing, um, inferring some really great things from that data. And that can either be identifying a really great problem to solve, a really great solution, and then really doing the legwork to identify the technical solutions. And it's not only technical solutions. I would say informaticists also, we are a lot of us are clinicians, and so sometimes the solution can be me just saying, well, let's identify a better workflow for that, because the solution always isn't technology. I think that's important to note. I would say half the time it's not technology, maybe more often than that, but really vetting the technology and facilitating the solution. It's not just me deciding, because I don't have the end all answers to everything, of course. And so getting the key stakeholders, getting the users all together to determine if this is the right solution for the problem we've identified through the data. If I hear a problem through a conversation, I like to support that problem with any of the data I can help to support that. As well. And then implementing that, I'd say in informatics includes reviewing the data, identifying the solution, and implementing the solution as well. And then post-implementation also, just making sure it's a success, because it's easy to launch something, but is it doing what it was intended to be doing is an important part of the process for informatics. So I'd say those are the kind of like the 4 areas of informatics.
Yeah, that's great. What advice would you have for somebody considering a career switch into either health tech or informatics?
I would say, just keeping the same theme, but making sure you understand your purpose behind that. To be candid, I hear folks say, and I understand this because I was one of them, I'm just burned out and I want to do something different. And there is nothing wrong with that at all. I think I felt that way. A lot of folks I talk to feel that way, but I think there should be an and after that. I feel burned out and I want to do something different. And I want to continue to help patients because I love technology, or I find it fascinating. I really enjoy data. I know that sounds corny, and I never believe people when they say that, but I enjoy data. I like finding patterns in data. If I didn't choose nursing, I would have chosen mathematics as my major in college. That was my minor. Actually, I love math, and I enjoy patterns, and so if there's a lot of messy data, I like going through it. And I think if that's, something you like, that's one angle. But I think just making sure that, you're choosing it because it's really something you want to do. It speaks to your purpose. It really speaks to any kind of passion that you do have. Just make sure I try to identify that, because that can be helpful. Because if you just switch to if you're just running away from the bedside, that may not be the right place for you. So just make sure you have the and after that. Yeah.
Yeah, that's huge. That's super valuable. I appreciate that. Well, I know we're coming to the end of our time here. Is there anything that we haven't discussed that you wanted to, or that you'd like to leave our listeners with?
Yeah. I would say, whenever you're in informatics and health tech, what have you, just make sure you really try to lead with the problem you're trying to solve. Yes, look at the data. That's important. Data tells you kind of part of the story, but really try to marry that with what you see happening on the ground. Make sure to listen to folks who are key stakeholders like nurses and physicians, and not just one or two of them, because many people can have very different perspectives. And so I think pay attention to it all the great data, challenge what you're seeing, but also, try to marry that with a lot of the great information you can get from those key stakeholders and kind of put it all together. To me, there's no secret, there's no one way approach, but I think, just trying to be a very good listener to those stakeholders and paying attention to the data. I always feel like the problem and the solution all lies in there somewhere. So I'll just leave it at that.
Yeah, that's great. If people wanted to learn more about your work or catch up with what you've got going on, is there someplace they can find you online?
Yeah. I have a LinkedIn, and I'm trying to be more active with it. It is, let me get it's Joe Martinez, RN, is at the end of my LinkedIn. But yeah, Joe Martinez, RN, pretty simple. And you can find me on LinkedIn. Yeah.
Perfect.
Feel free to connect. Yeah.
Yeah, that's great. Joe, thank you so much for being with us today and sharing your journey. And it's a really interesting, unique perspective. I love it because you boomeranged, right? Like you were in healthcare, then you went to tech, and now you're back. And it's really cool, all you've gleaned from that. So thank you for taking the time to share it with us.
Absolutely. Thank you so much, Ben. Really appreciate your time too.
For sure. To our listeners, we'd love to hear your thoughts and experiences on this episode. So you can share your comments on LinkedIn or directly on the podcast website at pivotal.buzzsprout.com. If you know somebody who'd find this episode inspiring or beneficial, go ahead and share it with them. They can listen live on LinkedIn or anywhere you get your podcasts. So stay tuned for more episodes here on the Pivotal Podcast.